Hello and welcome to our August Grand Rounds. Today we have Dr. Katie Terry talking to us about extremity pain and are we missing something? Dr. Terry earned her Doctor of Physical Therapy degree at University of Hartford, where she received staff recognition and leadership awards during her tenure. She earned a certification in mechanical diagnosis and therapy and is successfully nearing completion of the diploma in mechanical diagnosis and therapy, which is a task only several hundred therapists worldwide have been able to accomplish. Dr. Terry has been practicing in the orthopedic physical therapy realm her entire career and is currently the orthopedic program manager at physical therapy at St. Luke's Hillcrest. While treating patients with an array of diagnoses, she has worked primarily with patients with spine pain and pain of spinal origin. Her practice philosophy is comprised of a heavy emphasis on education and cultivating patient independence for self-management. So make sure that you, after finishing watching this, you complete the quiz and the course evaluation in order to get your certificate in the My eLearning platform. And if you have any questions, please feel free to contact me. My email address is steven.kareha@sluhn.org. And without further ado, I will turn it over to Dr. Terry.
Thank you very much, Dr. Kareha. Okay. So I'm Katie Terry, and today I'd like to talk about differential diagnosis of isolated extremity pain. All right. So okay, here is our designation statement for the network, and I have nothing to disclose as it relates to this presentation. So, learning objectives. Today I'd like to spend time identifying alternate sources of pain for isolated extremity symptoms, recognize cases in which spine evaluation is important for patients with extremity symptoms, find some symptoms that we can associate that might be good flags that say, okay, this patient would definitely need a spinal examination. I'd like to go through some research that's come out related to the prevalence of extremity symptoms of spinal source and apply concepts that we're talking about here to your caseload. See if we can't make earlier diagnoses, decrease duration of visits, and minimize recurrence rates. Dr. Kareha had made a really great point that the purpose of Grand Rounds is to initiate and enhance conversation amongst colleagues, so hopefully that's exactly what we can do today. So let's start with a case. If you took the time to answer the surveys a month or so ago, thank you so much for doing that. Some of the cases in this presentation will look really familiar. So case A, we have a 58-year-old male that comes into the clinic. He's had pain for the last week. He's got pain in the upper trap, periscap, deltoid region. He also has pain radiating below his elbow. Mechanism of onset is related to having reached quickly into the back seat of his car. He turned real fast and pain followed just thereafter. He's generally very healthy, and he was referred through the comprehensive spine program. His primary complaints are pain when reaching and just generally elevating the shoulder. So what do we want to look at for this gentleman? What baselines are we looking to collect? Any comparable signs? Any special testing that we want to do for this gentleman? So we know this is an isolated extremity symptoms, right? Bear with me here. So for this gentleman, obviously with any eval that we have, we're going to filter everything through a very detailed history. So we go through our history and we start thinking, all right, what could actually cause these symptoms? Well, he's complaining of his shoulder. Thinking rotator cuff, could be impingement, maybe arthritis, could it be some sort of referred pain from the neck or MI, diaphragm, could it be a malignancy? You know, I mean, we funnel through these things, right? So based on your thorough history, though, you're able to rule out a lot of red flags, and quite a few of these things off of your extensive list can easily fall off. So at this point, his primary complaints are related to his shoulder, but what will we need to assess upon survey, all of us agree we should also be examining his spine, not just his shoulder. Okay, so we're all on the same page with case A. So this next gentleman comes in. He's also 58. He's had pain for the last 20 years. He can point. I have it right in the very base of my thumb. He could use an eraser head to point to where his pain is. He reports that it's actually more just stiffness. He feels it when he's moving the thumb, when he's grasping, if he's picking up weights at the gym, if he's pruning shrubs in the yard. He really feels it. He's an architect, so when he's designing with his stylus, he finds that the thumb, it just feels really stiff. It's uncomfortable. The only time he has pain is if he bumps it. And his kids are getting older, his son's getting into wrestling, they're roughhousing more. So he's finding that he's bumping it more often, but the pain is exquisite, makes him jump out of his skin. He denies any symptoms anywhere else, and he cannot report any mechanism of injuries. Had this for the longest time, cannot figure out where it came from. No falls, no injuries, nothing like that. So for him, same thing. What do we want to look at? What do we want to collect for this gentleman? What are we going to special test? So again, we go through our history. What could be the cause of isolated thumb pain right here at the base? So, okay, could it be something soft tissue? Could he have a cyst? Could he have a fracture, some sort of contusion? Is it nerve, arthritic? We go through our funnel. So what if he goes on to say, I've had a ton of imaging and everything in the hand and the thumb looks really good? Okay, does that change things? So do you evaluate proximal to the location of pain? In school, they said, look one joint above and one joint below, right? So how far up? Do I go to the wrist? Do I go to the elbow? Would I look at the spine? Or do I just send this person to OT because they're in the wrong department? I don't do hands, right? So based on our surveys, just under a third of us said, I want to look at this gentleman's spine and rule that out. So what's the difference between these two cases besides the blatantly obvious? Case A, this distribution of symptoms are near the neck, sounds pretty nerve related. He uses the term radiating, right? So the mechanism of injury is inclusive of the neck for sure. Case B though, there's no indication of symptoms anywhere else. Walks like a thumb, quacks like a thumb, doesn't follow a clear distribution of patterns, that would make you think, oh, I should look at the neck. But what if you ask him, do you have neck pain? And he says, yeah, I do. What if he then goes on to say, I do have neck pain, but I don't think it has anything to do with my thumb. That's our decision to make, right? That's our correlation to put together. But we don't get to have that opportunity to make that decision if we don't ask the question. So again, our symptoms, case A, we have a pretty clear pattern that's pretty consistent with a mid to lower cervical pathology, radiates right down. Case B, these are isolated symptoms, but those isolated symptoms are still innervated. They're still part of a dermatome. So are we only suspecting a proximal source if our symptoms seem to be clearly connected in physicality and description to the proximal source? So what does the APTA say? They say, let's look at the spine. If you have a patient that has upper extremity symptoms that are referred or radiating, if your patient is over the age of 55, or if the patient confirms that symptoms are related to positions of the neck. So our first one, let's go right at it. Are we even asking if positions are related to, if symptoms are related to positions of the neck? If we're not asking this, we're leaving fries on our plate, man. We are totally leaving cards unturned. This is a great question to ask. How about the other point, if their patient's over 55? I would imagine in pre-COVID times, we would have a big room full of people. If I had asked, has anyone ever treated someone under the age of 55 who's had radiating symptoms, the bulk majority would indeed raise their hands. That's me just assuming. But what do we know about that? Lumbar radiculopathy has a lifetime prevalence of 60 to 90%. It's not age specific. We know it peaks at about 40 and 50 years old, increases for each decade thereafter, but it's not happening before then. Cervical radiculopathy, same thing, peaks at about 50. But again, it's happening before then. So if we're not considering it in those who are under 55, again, we're leaving some stones unturned. The North American Spine Society Clinical Practice Guidelines recommends that it is suggested that the diagnosis of cervical radiculopathy be considered in patients with arm pain, neck pain, scapular or periscap pain, paresthesias, numbness, sensory changes, weakness, or abnormal deep tendon reflexes in the arm. They're saying, consider this if your patient has arm pain, not arm pain in a specific pattern, arm pain in general. Symptoms of spinal origin do not always radiate, they're not always spread out, they may indeed be isolated. So why do we evaluate the spine? Rule it out, rule it in, either way. Some of the things that your patients might be coming in and saying, it feels like this wrist, it feels like it falls asleep, or I get this shooting, stabbing pain, might be like a nerve, similar to kind of nerve symptoms. Maybe it's pulsing, maybe it's disproportionately painful as compared to your contralateral extremity. What happens when they come in and they say, it's kind of came out of nowhere. I haven't really changed anything in my day, I didn't have any injuries. How about the patient who walks in with arthritis diagnosis under the age of 55 and there's no history of trauma? The IT band syndrome that, got out of the car after a really long drive and I got this IT band syndrome. Okay, it's interesting, right? How about the patient's like, my rotor cup is tore right on imaging, right? We all know about the tore rotor cup. It may be torn, but is that our pain generator? It's these situations that you want to be suspicious for your patient, not of your patient. Let's get interested, and that might spur some further questions. So let's look. So who's actually looking at the spine when a patient comes in with isolated extremity pains? Walker et al. Last year released a systematic review over 100 randomized controlled trials, and they were looking at patients specifically who had isolated shoulder pain. It's a very common diagnosis, limited diagnostic accuracy out there. There's a high correlation to the cervical spine, and there's no set way to rule out the spine that's consistent across our field. And their hypothesis was that this impacts recurrence rates. So if you break it down, they found that if a patient walks into your clinic with a diagnosis and a prescription of subacromial shoulder pain, 25% of therapists are not looking at the spine. Okay, the same patient walks into your clinic, and not only do they have this isolated subacromial shoulder pain, but they also have symptoms in the neck or radiating down the arm. 48% of these clinicians are looking at the spine in that case. 52% are still not. Nope, you came in here with this referral for this symptom. We're going to look at this issue. So now if you go down, just under 9% of clinicians are consistently doing a cervical examination, ruling out the cervical spine in patients who are coming with isolated shoulder pain. 2% are looking at manual testing. They're looking more at like segmental mobility, but again, on a consistent basis. Another 2% of clinicians are consistently looking at the cervical spine in these cases, only if the patient has a positive history of surgery. And just about 13.7% of therapists are using some sort of combined approach where the cervical spine is being considered, but in a less than full capacity. So we can agree that we're not all looking at the spine in isolated and non-isolated extremity symptoms, especially here for subacromial shoulder pain. So when you do the math, in our best case scenario for Walker's study, if a patient walks into your clinic with isolated shoulder pain, they have a 25% chance of having their cervical spine ruled out. So again, back to the surveys. For those of you who participated, we had just about 100 people answer the survey, which was really, really great. So per our surveyed stats in our network, approximately 32% of us are evaluating the spine consistently in patients with isolated extremity symptoms. So we beat out their results, which is great. We have bragging rights now. So how about this? You have a 48-year-old female who has this unrelenting right groin pain. She saw her doctor because it's getting worse, and he took a few x-rays and said, you have osteoarthritis in that hip. We got to replace it. Go to PT and strengthen for a couple weeks. She notices her pain worsens after she's been sitting on the couch, and she gets up. She can't really walk for exercise like she had been because she's limping so bad and has so much pain. She can't pick up her grandson. She's using a cane. She's a mess. If you ask her about back pain, she says, I don't have any. Okay, so there's one case. Again, it might look familiar. How about a gentleman who's 60 years old? He's in work boots all day. He works on steel plates on cargo ships for like 16 hours at a shot. He works for a few days in a row and gets a couple days off. He's had right foot pain. It's just under his heel, and it's driving him nuts. He's, oh, I'm limping everywhere. He's been through every pair of sneakers and orthotic you can think of. And he can't find any relief, especially with his long work shifts. He's a very healthy gentleman, denies any back pain upon inquiry, no other symptoms. So for these cases, for our 48-year-old female who's scheduled for a total hip replacement, would you rule out the spine or evaluate the spine? And about 3/4 of us said, yes, I definitely would. For our gentleman with isolated right foot pain, even though he stands on both feet all day, just about 1/3 of us said, I want to look at the spine. So again, these are the scenarios that you want to be kind of suspicious of. She's 48, she's pretty healthy. Arthritis. So now when do we need to look at the spine? When do we need to rule out spinal contribution? Well, let's look at some of the research, and this might kind of give you some input on what your odds are when you're looking. Last year, Richard Rosedale et al. Released a prospective cohort study. It was a study exploring the prevalence of extremity pain of spinal source. It's also known as the XPOS study. They collected data for about 12 months in New Zealand, Canada, Oregon, and Germany. They had a sample size that budgeted them a 95% confidence interval and 5% precision. The inclusion criteria were that patients needed to be referred to therapy with either upper or lower extremity pain that neither the patient nor the referring provider interpreted as having a spinal source. Patient needed to be over the age of 15, be able to attend PT 2 to 3 times a week, participate in exercise-based therapy, and understand English. Patients were excluded from the study if they had any inflammatory conditions such as RA, any evidence of recent trauma like swelling or bruising, neurological conditions that affected motor function, or if they were referred post-op. All of the therapists in the study had MDT training, otherwise known as the McKenzie method. But again, the study did not look at treatment at all, so this is not only pertaining to those who are studying the McKenzie method. Therapists, they would collect their history, collect baselines. The clinicians would assess the spine using end-range repeated motions and loading strategies. They then would recheck their symptomatic baselines and their functional baselines. If a correlation was noticed, the spine was further assessed. If not, they went on to assess the extremity. The key evaluation findings were the consistent baselines that were established. And again, they're looking at pain, patient's motion, and functional activities. So what they found in looking at regions, they looked at isolated extremity symptoms in the hip, the symptoms that are just in the thigh, symptoms that are just in the knee, symptoms just in the ankle or the foot. Again, isolated to just the shoulder, forearm, elbow, either lateral or medial, and at the wrist and the hand. What they found was that a total of these patients who were referred with isolated extremity symptoms, about 43.5% of these patients had symptoms of spinal origin. They were able to correlate all or a majority of their symptoms to the spine. So let's break this down a little bit more. So in the wrist and the hand, they found that 38.5% of the time, these isolated symptoms were of spinal origin. In the elbow, they correlated 44% of their cases to the spine. Isolated forearm symptoms were related to the spine in 83% of their cases. And at the shoulder, they were able to find that just over 47% of those isolated symptoms were of spinal origin. In the lower extremity, they found that just under 30% of isolated ankle and foot symptoms were of spinal origin. The knee was at 25.6%. The thigh, that just isolated thigh pain, had a 72% chance of being correlated to the spine, and the hip itself was at 71%. So this kind of gives you the odds of how often should I be ruling out the spine in a hip or an elbow or a knee. This might, change your thinking pattern. So prior research, Hashimoto et al. Released a study last year. Same thing, they were also looking at isolated extremities, isolated knee pain specifically. Their exclusion criteria was a little less rigid than that of the XPOS. If a patient had come in with symptoms that, I have knee pain, but sometimes my back bugs me and I get a little bit here on my hip. In the XPOS study, they would have been excluded. Hashimoto included them. They found that in over 100 cases that there was a 44.6% chance that knee pain was related to the back. And again, this was more isolated than radiating pain. Those were the symptoms they were looking at the most. In 2017, Carroll et al. Did a study looking at patients who also had shoulder pain. Shoulder pain is your top musculoskeletal complaint, and over half of these patients have symptoms for over 6 months' time. And in a McClatchy study, they reported that some of these cases actually had a high rate, up to 50% of recurrence in shoulder pain over the course of 3 years following treatment. So Carroll went to look onto this in patients who were referred for subacromial impingement syndrome. 14% of clinicians, and they had 365 cases in this study. 14% of clinicians suspected spinal origin after history in patients referred for this diagnosis. After examining the patient, 17% in addition then went on to say, oh, this might actually have a spine component, either cervical or thoracic. And then what they found that as these patients were being treated, 22% of the clinicians had to then change their diagnosis of periphery to the spine. So that combined near 40% total in their cases that they felt were of spinal origin. Cannon's study was interesting. They had patients that had been referred for electrodiagnosis evaluations with upper limb symptoms. They had patients that had radiating symptoms that were pretty indicative of cervical radiculopathy, but they also had a dual diagnosis of another musculoskeletal issue, whether it was lateral epicondylitis, de Quervain tenosynovitis, maybe an impingement. And they found that in 30% of the cases, they were looking at that the radiculopathy was actually impacting this unrelated musculoskeletal diagnosis. So it kind of makes you think, if your patient's coming in for they have this cervical radiculopathy, and maybe it stops just below the elbow, but they have this de Quervain down in the thumb. Is the de Quervain actually the most distal relevant component to that radiculopathy, and there's just a break in the distribution? Maybe, possibly, but they were saying that they were finding more of a correlation there than they had thought. And that may not be isolated extremity symptoms. Lee and Robinson looked at the elbow. They had over 100 cases, and they were looking at these patients with medial epicondyle pain over the course of 13 months. Patients were better after a month of treatment of the spine, after they had plateaued after being extensively treated for the medial epicondyle. So there was a drastic improvement in symptoms. These patients had just been kind of sitting there, plateauing, not getting better. Upon the change of their diagnosis, there was rapid improvement. And this happened in 54% of these cases. Of those 54% of those cases, 71% of those patients had been referred with bilateral medial epicondyle pain from their doctor. There was another study just looking at the lateral epicondyle, and there were reports that 70% of studies in patients with lateral elbow pain indicate pain in cervical or thoracic spine. They had hypomobility in the cervical and thoracic spine, and MRI findings were indicative of C5 and C6 degeneration on MRI. So you think about that. But lateral epicondylitis has a relapse rate of up to 50% in 18 months. So we'll kind of come back to that. So what does all this mean for your caseload, right? Encouraging you to rule out the spine. There was a study released by a group of PCPs, orthosurgeons, and rheumatologists. It was shoulder pain diagnosis and management in primary care. It was basically the what and how to do if a patient walks into your primary care clinic with isolated shoulder pain. Here's your history, right? They've got that long slew of questions that we're all asking. In the top half of those questions, ask about neck pain. They're saying to ask about neck pain before you ask about trauma or history of trauma. Ask about it before you're asking about their goals. Ask them about their neck before you even get into ADLs or what medicine they're taking. And then they say, okay, time to examine. The very first thing they're recommending is examine the neck. Look at it before you even look at that shoulder, right? Rule that right out. So they know what's going on, right? So if you go back to Walker's study, that systematic review, it's clear as a bell. They write, it's apparent that a proportion of patients presenting with subacromial shoulder pain have a relevant cervical component without obvious radiculopathy, i.e. movements and positions of their neck influence shoulder pain and movement. It's widely recognized that the cervical spine should be examined and excluded prior to more specific diagnosis implicating the shoulder. Boom. I mean, that's black and white right there, right? So again, when do you do it? Think about your odds. I have 47% chance of it being of spinal origin in the shoulder. even in the knee, it's only 25% chance. Those are still odds I'm not willing to gamble on. I think it's still worth examination in my practice. Again, how do I know? We have to ask the questions. Ask your patient, do you have any back pain? No, my back feels fine. Do you have any history of back pain? Yeah, actually, I do. What does that mean to you? It might be worth an assessment. So how do you want to go about assessing it? Again, to go back to the North American Spine Society, they say for any spine assessment, you want to look at active range of motion. You want to look for that any aberrant motion. Maybe you're doing a slump test, straight leg raise, upper limb tension testing, and then your reflexes, sensation, and muscle resistance. Do a neuroscreen. If the patient comes in and they have pain in their elbow, and you are testing their sensation, but they have a loss of sensation down into the forearm or near the thumb, well, we're talking about 1 or 2 different dermatomes here maybe, and maybe we're not actually talking about isolated extremity pain anymore, are we? So again, how do we test this? How do we rule this out? Comprehensive spine program. What they're doing, and again, yes, they're getting referrals for the spine, but if we're going to assess, or if we're going to rule something out, we have to assess it. So assess the spine. Every patient gets a neuroscreen. We're looking at sensation, reflexes, spurlings, distractions, straight leg raise, cross straight leg raise, and we're doing a repeated end range motion examination. That's going to really give us a chance to identify a mechanical problem in the spine. It's going to give us the opportunity to establish a direction of preference. And if we are able to do that, it's not only diagnostic, but it's prognostic. It's safe for the patient. You do a bunch of special tests for other joints, consider this the same thing. This is another way to special test. Again, you're looking at end range versus mid range. We live in mid range all day. End range will really expose something, especially if you have a patient who says, no, I don't have any neck pain. So doing repeated extensions or something of the like shouldn't really cause a problem for them. If it does, maybe we've exposed something that they weren't aware of, and whether it's related to our symptoms or not, we'll delve into that. At the very least, again, we're talking about something that seems so disconnected maybe. My thumb though, why are you looking at my neck? This is going to give us a chance to really connect. I just moved your neck and it changed your thumb. This is going to expose a relevant mechanical component and help us put the pieces together a little bit more for our patient. We want to establish solid baselines. Again, just like what they did in XPOS, get those solid baselines. Our clinical practice guidelines tell us that clinicians should utilize easily reproducible activity limitation and participation restriction measures associated with their patient's pain to assess the changes in the patient's level of function over the episode of care. It means not just baselines, but meaningful baselines, something that's relevant to your patient. If you go ahead and throw in an empty can test, that might not mean anything to your patient, but you know what does? When they try to pull the milk off the top shelf in the refrigerator, get a free weight, pop it on the shelf. Does that feel like it does when you pull the milk out of the refrigerator? It does. Okay, great. We've got a baseline that we can work with. So say you do your repeated motions and your patient centralizes. This can happen. This can happen in non-radicular pain. Again, this is not, you want to educate your patient. This is not robbing Peter to pay Paul. You haven't swapped one injury for another. You have relocated this, and in 70% of patients with mechanical deficit in the spine, they will centralize. So this is a great thing. Embrace it, educate. It's going to absolutely require education. We're going to talk about that in a second, but this is a really positive finding, and it's going to help make it connect the dots again for something that seems so disconnected. So your next eval comes in. Again, why are you looking at my neck? I told you my thumb hurt. We have to go back and forth with this patient, right? We have to take from them what we're able and give back to them, right? We have to get information from them and give them meaning for it. What does this even mean to them? I like to tell my patients, I want to look at everything that might be contributing to your thumb pain, and the spine can do that even if it's not hurting. I'm hearing you that you don't have neck pain, but I just want to make sure that I'm looking at any potential contributing factors, and if we turn over all these stones now before we just hone in on the thumb, it's going to make me develop a more specific care plan for your thumb. We can come up with this game plan together. Again, we go back to our thumb case. This guy has had pain for 20 years. Bear with me for just a few minutes. It's a drop in the ocean at this point for this gentleman. So again, we're recommending do a neuroscreen and rule out the spine. This takes up to 4 minutes if you are doing a neuroscreen for the lower body and repeated end range motions for the low back. Same thing for the upper body and for the neck. Doesn't take that long. If you want to include a thoracic exam for someone with upper extremity symptoms, maybe it takes 5 or 6. So then you're left with, well, whatever time's left over after the whole the screening process of, is anybody hurting you at home? And they're, oh, I live with a cat, and everybody who lives with a cat is getting hurt at home, and we got to talk about the cat for a little while. So now we're down to 30 minutes. But again, we want to get information from the patient. We want to educate them as to why this is relevant and what it can mean. Because again, this thumb seems pretty disconnected from your cervical spine, right? We have to connect the dots between their experience and our knowledge. And we want them to be on the same page with us. This is their care plan. It's not just our care plan for them, right? Give them the opportunity to self-advocate. If we're spurring an internal locus of control with these patients, self-efficacy is going to soar through the roof. You're going to have a patient that's going to have a lot better carryover, going to be able to work with you more closely in your care plan. Again, you take the time to explain why we're looking here. Not only shows that you're interested and you're knowledgeable and that you're thorough, but you're validating the seriousness of their complaints. And when you incorporate this education and correlate it to their goals, they're going to be a lot more on board. So again, it really is a lot of education to connect the dots. So your eval walks into your clinic. Again, they come in with these prescriptions, and but we have to evaluate who's in front of us. How many times? I mean, there's over 20 special tests that we could do for rotator cuff tear, and maybe they're all positive. But if we're not ruling out the spine, we're not looking at everything. Again, you know, we look at this research, the percentage of this correlation is higher than, that I would personally expect, and that's just me, but it's higher than previous research had indicated. Think about our practice guidelines for adhesive capsulitis. Our practice guidelines suggest that we should consider a diagnostic classification other than adhesive capsulitis when the patient's reported activity limitations or impairments of body function and structure are not consistent with the diagnosis section of these guidelines, or when the patient's symptoms are not resolving with interventions aimed at normalization of the patient's impairment of body function. We just wait for them to not get better. If I see an adhesive capsulitis on a Monday and they come back to me on Wednesday and they're a whole lot better or they're a whole lot worse, I might not be working with an adhesive capsulitis. I might be looking at something else. So it's worth it to rule out any potential contributing factors. We don't want to just sit on it and wait for it, right? Treat the person who's in front of you. So again, we think about our profession, novice versus expert clinicians, right? Novice clinicians, right, they go through that huge funneling process. They're going through all that hypothetical deductive reasoning, all this narrative clinical reasoning. They're going through all of it. They're in the forest and they can't see the trees, right? We're all like that, you know, in our first year or something. But then you have the expert clinicians. They're looking at pattern recognition. I saw you get out of your car in the parking lot. I don't even need to evaluate you. I know you're a back, you're not a Nate, right? They pick up on these things, but we have to meet in the middle, right? And so when we look at through all this research of where the most effective clinicians are, they're finding that the most effective clinicians have a really solid history and they can do a pretty basic physical exam on that. So we have to ask the right questions. We have to get the right information because that's only going to give us a fair fighting chance to evaluate the things we need. When your patient says, oh, I get up and it hurts, but then I start walking and it feels better, versus I get up and then after I start walking, it hurts. That might indicate two different body areas for us, maybe. But we should always ask, but where does it hurt? And we can't just assume that it's the hip that hurts when they're describing this. You know, when they come in with this prescription of hip OA or IT band, maybe they point to their back. Again, are we now dealing with something other than an isolated extremity symptom? Asking the question, do you have any current back pain or history of back pain? What does your patient say? No. That's very different than asking, do you have any current back pain? No. Do you have a history of back pain? Yes, as a matter of fact. Great. Again, we have to ask these questions in a fairly specific way. Doesn't hurt to ask, do you have any symptoms anywhere else? Oh, no, it's just really my knee. My foot goes numb sometimes, but again, are we looking at isolated extremity symptoms or are we looking at something different? That's our decision to make once we've ruled that out. Always ask about distal locations, test the distal locations. Again, it's not that time consuming and it's absolutely worth it because we as the clinicians would much rather be able to put that painful knee and that stiff hip. We'd rather put the two of them together than the patient come back and say, you know what's interesting? When my back bothers me, my knee really bothers me. We want to be able to put that together before our patients, right? Again, just Be interested, be suspicious for your patients, not of your patients. Ask these questions. So, okay, so when do you revisit? Say you had them on eval, you screened the spine. I did what Katie said. I rolled out the spine. I already did it. Great. And you move on and you treat the periphery. Well, the nice thing about what we do is our patients come back. We see them day 2. Maybe we didn't get all the information we needed day 1. We can keep collecting information day 2 and on. We should be able to reassess to a certain degree each session. So if your patient's plateaued, maybe we need to revisit the spine. Maybe there was something contributing that we didn't see before. Maybe you've developed a stronger rapport with your patient as visits have gone on, and they then reveal, oh yeah, but I haven't been sleeping at night because my back has been driving me nuts, and oh, my back gets mad. It really, bothers my hip. So then, there's a little something there. But maybe we just didn't ask the right questions on eval, and I didn't give my patient the opportunity to share that information with me. Maybe I just didn't ask them enough, or I didn't ask in the right way. And it happens. So think about our recurrence rates. I was able to look at our network photo scores. I looked at our effectiveness scores that Rhett was able to share with me. So to say that we're near 100% is pretty awesome. I mean, just in the team that I work with, these are incredible clinicians, and I know that the rest of our network is just as incredible. So you see these therapists doing amazing things each day. So it doesn't shock me that our effectiveness score on photo for our hip is 94%. That seems pretty great. So what about like in the shoulder though? It's 89%. The elbow's 78% effectiveness. Wrist and hand is 80% effective. What does that mean to us? We can go back to the Carroll study that we had mentioned earlier. There was about 20% of clinicians that had to change their diagnosis from the periphery to the proximal, after a certain amount of sessions. Are we catching these things early enough? Maybe that's what we're seeing, or maybe we're not seeing, right? Our overall ortho predicted visits in photo are 12.1 visits, and we're actually at 12.22. I mean, that's pretty much on the money, but will we be any lower if we were checking things earlier? Maybe, I don't know. It's just something to think about. So, okay, one more case. It was a 64-year-old female. She fell on her left shoulder 6 months ago. She was scared she would break her hand if she put her hand out, so she tucked her hand in and she smashed right on that shoulder. She's had bruising and mobility issues, but she's about 60% better now. Her primary complaints are general shoulder mobility when she's reaching. If she's going to put the driver's side seatbelt on, she has pain with that, and she really is having trouble sleeping on her left side just due to that shoulder pain. She's a pretty healthy lady. Would you evaluate the spine in this lady? Well, about 2/3 of us said, yeah, I would. Great. So what about now? Now that we just talked about all of this, same questions. What are you going to look at? Are you going to look proximal to the shoulder? Well, what's the % chance that these symptoms could be related to the spine? Like 47%. So that might change something. Lo and behold, all of the cases that we discussed so far did resolve with spine intervention solely. So I think that's pretty interesting. So future research and future patients, because it's coming down the pike and they're going to be on your snap board on Monday. Think about our recurrence rates. Are these things really recurring, or are they getting, think about these frequent flyers. Up, that knee arthritis, it's flaring up again. Yep, every year it does the same thing. Maybe it does, but is there something else to it? So here, what about this argument? Someone's probably been screaming this whole time. What if you treated the periphery? What if we treated this guy's knee OA last year? We hammered him with long arc quads, short arc quads, got him on the new step, doing sit to stands and squats, all the things we do. Okay, great. He got better. Treated him for like a month last year. Took a couple weeks and he felt like $1 million. Great. So why did he get better when I treated his knee? And then when he came back this year, I evaluated his spine, and lo and behold, there's a spinal component there. Well, what do we know about the natural history of low back pain and radiculopathy? 80-90% of these cases are going to recover in about 6 weeks. It's really only like 7 to 10% of these cases that go on to become chronic pain that leaves them completely disabled. So that might line up with your treatment time. Well, I treated him for about a month. Maybe this got better, not necessarily because of what we were doing, but in spite of what we were doing. The human body is amazing How many times do we get a patient that comes in through the comprehensive spine program, see him on a Tuesday, and oh yeah, I was really in pain this weekend, so I called the line and I feel bad. I don't want to take your time up, but I feel a lot better now, right? These things get better. Human body just does pretty neat stuff, right? So I looked at my own stats, and not that I have that much free time, but I looked through my patients who have isolated extremity pain. At the shoulder, I found that about 50% of my cases that had isolated shoulder pain were of spinal origin. The hip, I was at about 75%, so similar to the XPOS study. In the knee, I was about 40%, so I was a little closer to Hashimoto's work than the XPOS study. And in the ankle and the foot, I found that about 30% of my cases with isolated symptoms were of spinal origin. My sample size was much less than the XPOS study, but I just thought it was interesting and kind of good to know, am I missing something as it correlates to the most recent research. So think about maybe the last couple of cases that came in. What do you find, out of the last few elbows or knees that showed up with isolated pain? Did we rule out the spine? Maybe not. Maybe it's worth looking at, another time. Think about the patients that you have on caseload that you're wrapping up with. Do they have deficits elsewhere? Did this knee issue, create a limp, irritate the back? It's worth a screen. Maybe we're digging something up that we hadn't seen before. And we really don't need to say we have to do it all the same exact way, but we should probably agree to be looking at the same things. And that might have a stronger impact on these recurrence rates. So basically, in review, isolated extremity symptoms, they have a higher rate of correlation to spinal source than previous research has indicated. If we ask the right and more specific questions on eval, it's going to give us a little more insight as to what body regions may benefit from evaluation. If we're really educating our patients as to why we're assessing these varied regions, it's going to not only increase our therapeutic alliance, it's going to give us a better chance to create a more clear prognosis while we're ruling out differential diagnoses. A neuroscreen and end-range repeated motion testing is not time-consuming. It's easily incorporated into your evaluation. The more often you do it, the quicker you'll get at it. And if you miss it on day one, really try to get it on day two. It's absolutely worth it. Stay interested in your patient. Minimize these recurrence rates. It's absolutely worth it. Again, the purpose of today was to start or enhance a conversation, and hopefully it did just that. I think we have the coolest job ever. So if you'd like to talk a little bit more about this or have any questions related to references or anything along those lines, please feel free to reach out to me. I'm at katherine.terry@sluhn.org, or you can find me on Teams. Thank you so much for your time. I really appreciate it. Go get them.